Hello, and welcome to the Thrive Mindset Podcast. I am so glad you are here with me. My name is Carrie Dahle, and I am your host. I am an entrepreneur, author, podcaster, manifester, and motivator. And I am on a mission to empower you to create the life of your dreams. If you are looking to up-level your life, relationships, finances, productivity, and success, you have come to the right place. I will share with you tools, resources, strategies, my failures, and my successes that have all helped me achieve the life of my dreams. It is my goal with this podcast to help you see your potential and empower you to create the life of your dreams. So let's get to it. Welcome back to the Thrive Mindset Podcast. Today, I want to do something a little different. Normally, we talk about thriving in our mental state, or we talk about thriving in our businesses. But today I want to talk about thriving in our health, and specifically women's health. So I am very blessed and lucky to have Dr. Maria Canter here with us. And we are going to talk about all the things that no one talks about: your pelvic health, your sexual health, all the things that you really should be taking care of as a woman so that you can thrive in this world that way too. Welcome, Maria.
Thank you so much for having me. It's so fun to be here.
Oh, I'm just so excited to chat with you. But before we dive into all of that, can you just share a little bit about you, maybe your story, maybe how specifically you were drawn to working with women in this way?
Sure. It's kind of funny. I knew at a pretty young age I wanted to be in medicine. Don't know how that happened,
Mhm.
but I did. And somehow, by the grace of whatever, God, the universe, I ended up in the medical field and I found myself really interested in cardiovascular surgery to begin with, specifically taking care of newborns with heart defects. But somehow I found myself doing a rotation in urology and I really enjoyed it. It was a lot of fun. Urology has a lot of immediate gratification. You have pain in a stone one day and the next day the stone's gone and the pain's gone. However, I also enjoyed women's health.
Mm.
And I had a resident in urology pull me aside one day and say, "Hey, I know you really like women's health. I know you're really loving procedures in urology. There's this thing called urogynecologist. You should check it out." And I did, and I fell in love. So I did my residency in obstetrics and gynecology, which was amazing. I delivered over 1,000 babies, and it was so incredible to witness bringing these children into the world and working with families. But then I did a fellowship to work with women who, after having had deliveries or just time, bodies changing, were having difficulties with pelvic floor. And so I did urogynecology as a specialty.
Wow. I love that. And I love the passion and the way you just lit up talking about it, because it says so much about who you are and why you do what you do. So thank you. Thank you for doing that.
Well, thank you.
I don't even know where to start. Other than to say, well, you and I chatted before, and there's lots of areas that women don't realize. Number one, it's normal. It happens to them. It happens to a lot of people. And number two, don't know what to do. Like they just think this is part of aging.
Sure. I mean, you're right. I mean, this could be multiple podcasts, probably.
No, it could be. We're gonna do whatever we do today.
There's so much to cover. So, in the world of urogynecology, we help women who have pelvic floor dysfunction, and that can be pelvic organ prolapse, which means that there is descent of one or more organs through the vagina. So, the bladder could be coming down, the rectal area could be coming down, the top of the vagina if you've had a hysterectomy, the uterus if you haven't. So, things could be coming down through the vagina, can be very distracting. It almost feels like a tampon was placed in the vagina and it's just displaced and you feel it all day and it really bothers you.
Oh.
We also treat urinary incontinence, which is the involuntary loss of urine. So an example of that, as many people know, over 50% of women probably have experienced urinary incontinence. But an example of that would be let's say you're playing tennis, every time you hit that ball, you feel something happen. You might lose a little urine. And so we treat that as well.
Mhm.
Things like fecal incontinence. So some women have the same issue, but it's stool that comes out instead of urine. And then there can be sexual dysfunction. Some women have a baby or something else happens. They go into menopause and they start to have discomfort with intercourse. Sexual function changes a little bit. So there's many, many aspects to what we do. We see a lot of urinary incontinence, but we also see a lot of prolapse, some fecal incontinence, and definitely some sexual dysfunction.
Do you think, well, I don't even know how to ask this because I don't know, I don't do your job, but do you see more with women who have had children, or is it equal either way?
Yeah, so definitely women who've had pregnancy, especially vaginal delivery, but even with cesarean sections, we can see an increase in pelvic floor dysfunction for sure.
Mhm.
Women who have had a vaginal delivery have a twofold increased risk of stress urinary incontinence compared to other women. So,
Yeah.
definitely pregnancy and deliveries can contribute to these disorders.
hmm well, yes, I will just say yes. And then I would assume age too, right? Because I mean, as you get older, I mean, my girlfriends and I joke, like, don't, as you get older, don't sneeze. You might pee yourself. I don't know. But
No, it's true, but I think what a lot of people don't know is there's a lot of things, there's many treatment options, and I feel that many patients will come to me just, oh my gosh, does this mean I have to have surgery? And sometimes surgery is the right option for them, but not always. Sometimes there are other options that might be fine for them that don't include surgery.
can you share any of that? Like any of what those options are?
Ooh.
That's not surgery.
Absolutely. So let's say a patient is having stress urinary incontinence. And so that means that when there's a stress on the abdomen, so a cough, a sneeze, a laugh, for some women it's just standing up and they may experience some loss of urine. Lots of treatment options for that. So, barring any issue with prolapse of the bladder or the vagina, we could offer pelvic floor physical therapy, where you meet with a trained specialist in pelvic floor muscles, ligaments, bony structures, and they can teach you exercises to strengthen your core, but also strengthen your pelvic floor muscles. This can look a lot like Pilates. And
Mm-hmm.
a lot of pelvic floor physical therapists will get your core strengthened, teach you your Kegels, and then help you transition into something like Pilates so you have a lifelong treatment for yourself, and you can keep up with that over time.
Mm-hmm.
Another option would be a vaginal insert or a pessary. So, an example of this would be a patient who puts a tampon in to go for a run. I do have patients who do that. There are companies that create something like a tampon that you can put in the vagina to go for a run. Those can work great for some patients. I only see people these things don't work for or
Yep.
don't like them, for whatever reason. But that's another example. In my office, we have something called a pessary. A pessary is a type of vaginal insert. It's usually made of like a silicone, or you can think of it like a rubber type structure. It can be shaped like a ring or like a little shallow dish. Lots of different shapes and sizes, but those two shapes in particular are used to obstruct the urethra to a degree to help with urinary incontinence. So if you allow me to use my hand here, if your bladder's here and your urethra's here, if you're active, that urethra, one of the issues might be urethra wiggles a little too much. And when that happens, if there's something kind of in its way, it can catch and kink around it. So you
Mm-hmm.
could see how a tampon or a pessary or something like that might be helpful in preventing urinary leakage when you're active. Pessaries are pretty easy to use for most patients, unless you have arthritis or issues with dexterity in your hands. In that case, your provider would help you with it, but you have a little fitting to make sure it's the right shape and size. You're taught how to place it and how to remove it. You take it out periodically to wash it. Sometimes you can take it out every day, or you could take it out once a week. It just depends on your circumstances. You could even go longer. And then there are surgical procedures or little procedures as well. So things like slings, probably a lot of patients have heard about sling surgeries. These have been our gold standard, although I see a lot of this other procedure kind of up and coming lately. I don't know if it'll replace slings as gold standard, but it's definitely becoming more popular. So I'll talk about the sling first. Again, you've got your bladder here, you've got your urethra here. And what we do is make a little incision in the vaginal area underneath that middle of that urethra. And then I take a ribbon of graft or mesh and we fold it and place it underneath the urethra like this. So when you're active, your urethra will kink around it and hopefully you're dry. For most patients, we see about an 85% success rate with that at 5 years,
Wow.
meaning 85% of patients are satisfied or very satisfied with the procedure. But of course, it's not the same success rate for everybody, and there can be other factors that contribute to that. What I was getting to with the other procedure is a bulking procedure, which has been around for a long time, and it's traditionally been a procedure for someone who has a very, very weak urethra. So again, if we look at the bladder's here, the urethra's here, right? And if you imagine going up into that urethra, like the tube here going up into the bladder, like the balloon of the bladder, we can go into this little urethra and inject medicine in here so that it tightens and tightens and tightens. It's a pretty minimally invasive procedure. With it, there's little to no restrictions. In fact, I have quite a few runners who we were planning on a sling and they came in and said, actually, I want to try the bulking first because they didn't want to stop running.
Yeah.
And so we did their bulking procedure. It's not quite as successful as a sling procedure. The success rates run about 60% or so, but there's no restrictions. They can go for a run the next day. With something like a sling procedure, you have incisions that need to heal. We need to give you a little time. We ask patients to kind of take it easy for about 6 weeks before they're running again.
Hmm.
But it's a wonderful problem to have all of these beautiful options that you can choose from. And based on your medical history, based on your circumstances, you can decide which option works best for you.
Yeah. I love every bit of that actually. And I love that you're talking about running because I can only speak personal experiences, right? I can't speak for everybody else, but I can just say I just know in my mind things that I think about, right? Things that I gotta go pee before I go out for a run. I've got to do this. I'm not gonna
Right.
go or like for a race. Okay, did you hit the bathroom?
Absolutely. And you're not alone.
No,
And
and
that's
it's not like it's like a lot, but it's enough that you notice and then it's why? Like why?
absolutely. And you're not alone at all. I mean, I have a lot of patients who'll tell me I got to wear black yoga pants every time I go
Oh,
here or there or whatever because they're afraid that it might show when they go for a run or
yeah.
they're on the tennis court or whatnot. But the beauty of it is that there are a lot of treatment options. We
Hmm.
will typically start with pelvic floor physical therapy,
Hmm.
and pelvic floor strengthening. If it's pretty severe leakage, we may evaluate you for more invasive procedures a little bit sooner rather than later. But certainly, pelvic floor physical therapy is a great starting point.
Yeah. Yeah, I love that too. And who doesn't want to do Pilates? I mean, come on.
Good
It's
for everything, right?
yeah, it is. It's good for everything. You're absolutely right. So another thing that you mentioned before is incontinence.
So, incontinence is an involuntary loss of some fecal incontinence where you lose your stool. And so, as you can imagine, fecal incontinence is quite debilitating. I
Mm,
mean, these poor patients, they socially isolate, they're afraid to leave their homes, and they really need to be evaluated. Even if you're just thinking, like, I don't want a surgery, I mean, you have to be evaluated for that. We need you to have a colonoscopy, a GI workup, make sure you don't have some other thing going on like an inflammatory bowel disease, or you might even have irritable bowel syndrome. But if those things have been ruled out, it could just be that you have a weakness of your pelvic floor muscles.
mhm,
And again, we would go to pelvic floor physical therapy. We'd go to things like fiber supplements to bulk the stool. We would go to an occasional Imodium, maybe, if you're going to be eating out or you're concerned about activity and losing stool.
mhm.
Lots of ways that we can manage that. But incontinence is essentially an involuntary loss.
What about sexual health? What about that do you think is important to discuss?
Well, with sexual health, there are so many aspects of sexual health. When we talk about the domains of sexual health, we talk about libido, right? So the desire to have sex. We talk about arousal. So when your body's getting charged up, orgasm. I think we all know what that is.
Yeah, I think
But we also
I would
talk
hope
about,
so.
right. We also talk about pain. So some women will have pain with intercourse. It might be because they had a delivery or a surgery, or maybe they're in menopause, or maybe they have some trauma or other chronic pain issues that are holding them back.
Mhm.
We talk about lubrication and how well the body lubricates in preparation for intercourse. And we also talk about satisfaction. And there's so many aspects. It's funny when I talk to patients about sexual health and orgasm, we talk about, well, with the men, it's usually one thing. If they have a problem, it's usually a blood flow issue. Usually, it can be other things, but usually it's a blood flow issue. With women, we're so complex in a beautiful way.
Mhm.
There's so many aspects to us. And so we have to look at so many aspects of this. The way you were raised, culturally what you believe, maybe religious issues or concerns that may come up. But aside from that, there are, issues with libido that can happen. Maybe because as a menopausal woman, for example, you might have some low testosterone. There's actually a global consensus on the use of topical testosterone in menopausal women for decreased libido. We call it hyposexual desire disorder. Hadn't thought about that in a minute. But, we can treat patients with topical testosterone, bring the testosterone levels back up and help with decreased libido. So that's an example there.
Mhm.
Orgasm is quite complex, as you can imagine. So many factors that come into play when we talk about orgasm. So if a woman's never had an orgasm, we need a sort of a holistic team approach to figure out why that is. Is there something neurological going on? Is there something psychological going on? Is there a physical component to it? So we have to kind of weed through that to figure out what is causing that. If she's had orgasms before, but not able to have orgasms anymore, then we want to look at what changed, and an example of that might be a woman is in menopause and maybe she's had decreased blood flow to that area. And what can we do to improve that? Well, we could use some topical estrogen, really simple to use. So many benefits of estrogen. Oh my gosh, I think you could do a whole podcast just on estrogen. Vaginal estrogen, replenishes the deficit really of estrogen in the genital area. So when you think about it, if you have a thyroid issue and your thyroid isn't working anymore, your doctor gives you thyroid medication. If your body is unable to function in an appropriate way to manage your sugars, then you get medicine to manage your diabetes. But if your ovaries stop working or stop creating estrogen, what are we to do? Right. And so topical estrogen can be quite helpful in keeping the pH level of the vagina in a good place. So the vagina loves a lower pH level. It helps keep out the bad bacteria that can cause urinary tract infections and allows the good bacteria to thrive. And also increases blood flow to those areas, which can be quite helpful when we're talking about issues with sexual function.
Mhm.
Furthermore, when you're increasing blood flow to the area, that can also help with lubrication and also when women get pain with intercourse as a result of dryness of the vagina from a lack of estrogen. Then we get into things like, pain. I think we've kind of touched on that. The thing about pain is that when it's chronic, we usually need a little help. Oftentimes, the brain will take over in a way to protect you. And the brain and the vagina start to have a miscommunication. So that's a time when if someone's had chronic pain for a year or many years or whatnot, we may want to consider some cognitive behavioral therapy or sex therapy to help reprogram what's happening between the brain and the vagina.
Yeah. I am really curious because a lot of these are definitely hormonal things, right? And I think that, and I'm again, this is just me speculating, but I think when you're in that time of your life and you're having babies, and especially right after you have babies, your hormones are so all over the place. And then I feel like this starts to happen again to you in perimenopause and menopause, and they seem to kind of correlate with how at least a woman emotionally attaches themselves to sex, right? You just feel this distance or less desire. And then, I mean,
Oh my gosh.
yeah. But I was thinking about it the other day because somebody had made the comment to me. I don't know, it's been a while now. For years and years, I haven't eaten meat. And somebody said, "But did you at all when you were pregnant?" And I'm like, "Actually, I did."
Mhm.
And they were talking about the fact, the parallels between your hormones then and now, right? And as I'm getting older and things are changing, and I thought, I'm wondering, as I'm listening to you, I'm wondering how those two compare. Do you see the similarities there, or am I just being crazy?
No, you're talking about the like the postpartum, perinatal,
Yeah.
postpartum era versus perimenopause. Oh
Yeah.
my gosh, you're a genius. It's so true. It's amazing because a lot of postpartum women have the same issues as a menopausal woman.
Mm.
In fact, a lot of times, almost 100%, maybe 100% of the time, when I see a postpartum woman in my office, she gets vaginal estrogen and pelvic floor physical therapy too.
Mm.
And a lot of times they're coming to me because they're having pain with intercourse. And what's happening is, especially if they're nursing, right? When you're nursing, you're not producing the same kind of estrogen that you did before,
Mm.
right? And so the vaginal tissues are getting dry, they are uncomfortable. Oh my gosh, if you had a laceration or an episiotomy with your delivery, it may be struggling to heal because you don't have good blood flow from a lack of estrogen. So we can treat you with a little vaginal estrogen, and that can help. So you're absolutely right. These ladies are void of estrogen. It's just a cruel joke, really, because here you are not sleeping at night. You've got this baby,
Mm.
in the other room or next to you somewhere, like crying, waking you up, and you don't have any estrogen. You're, 6 weeks after delivery, you're not supposed to be having sex. And then there's sometimes great anxiety about having sex again once you've delivered.
Ah,
Like, wow, my body's different now. Is this going to hurt? Is it going to be okay? What's going on? And so we talk about things like lubricants, which I also talk about with my menopausal women who have some discomfort with intercourse. So you are absolutely right.
well, I'm glad to know I'm not crazy.
No.
It just seems so logical to me. I mean, it was a random thing, but as you were talking, I kept thinking, oh, this actually, it has to make sense. And I think it's really good to talk about it because just like we don't, or the world hasn't been known to talk about, depression and different things that happen after you have a baby, we're doing the same thing with perimenopause and menopause. And unless we talk about it, it's just going to be on the shelf and no one's going to know that they're normal and that this is happening to all these people or that these activities or these behaviors are not just them, right? And I think that's so
Absolutely.
important to know it's not just you, that so many women
Absolutely.
are experiencing the same things. What else? What else do you think would be really important to share that we maybe haven't talked about?
Well, we haven't talked too much about prolapse. And although it doesn't affect as many women as, say, urinary incontinence, it does affect some women, and sometimes dramatically. When your organs are coming through in the vaginal area, it can be really uncomfortable. And when it's worrisome, most worrisome is if you're starting to have recurrent urinary infections, which we can talk about that as well. But when you're having recurrent urinary infections, say with the prolapse, we can revisit like where the bladder is, the urethra is, and then the bladder's coming down, right? And here's the opening of the vagina, and there's a bulge. It can be like a pink ball hanging out of the vagina sometimes. And you get a little kink here in this urethra. And so with, say, a surgery or pessary, we would pull this back up, right? There
Mhm.
wouldn't be a kink there anymore. But if this bladder's falling down, there's a little kink there. And so when that happens, you may not be able to empty your bladder well or at all.
Hmm.
And that can be a problem. So if you're having recurrent urinary infections, we might be concerned that maybe there's a component of the urine that's in the bladder that's not really kind of swirling around enough to get out, and it's like a little spa for the bacteria.
Oh,
So we would want to support the bladder, So if you're not emptying your bladder, that's also worrisome because urine can back up to your kidneys and cause a problem. Now, most women will know when they have these issues, recurrent UTIs, or they're not emptying their bladders. Once in a blue moon, I have a patient who won't be aware that she's not emptying her bladder that well. So if you have prolapse, it's a good idea to have it evaluated. But treatments for that would include physical therapy depending on the degree of prolapse. So, in my experience, prolapse that's really hanging outside the body, it's pretty difficult to pull that back up
hmm.
with pelvic floor physical therapy, with one exception, postpartum. Women who deliver a baby and right after the delivery, they may have prolapse. I have actually seen these women go into pelvic floor physical therapy and pull things back up. It amazes me every time, but I never rush those ladies to surgery. We might do a pessary, but I always give them 6 to 12 months to recover because a lot of times they can do some pelvic floor exercise and really get things back up where they were before. And it always amazes me. But otherwise, we can do pelvic floor physical therapy if it's not a severe or extensive prolapse.
Mhm.
We could do that pessary. So just like there are pessaries for incontinence, those incontinence pessaries can double as pessaries for prolapse, but also there are pessaries designed for different types of prolapse as well. And so you would come in for a fitting and we could support you in that way. And again, the pessary can be taken out periodically for our menopausal patients and our postpartum patients who aren't having regular periods. We do recommend a vaginal estrogen just to reduce your risk of urinary infection and discomfort and bleeding and ulcers and things like that, which are unusual with the pessary but could happen. And then there are surgical options. And for prolapse, the goal of surgery is either to pull things back up or to alleviate the prolapse by doing what we call an ablative procedure. So there are surgeries we can do through the vagina that restore the vagina to where it was. There are surgeries we can do, say, laparoscopically or through the abdomen to pull things back up to restore the vagina to where it was. And there might be some patients who are maybe they're elderly, they're not in great health, they cannot or are not interested in having intercourse through the vagina in the future. We have what's called an ablative procedure, which means we can essentially close the vaginal area. So you can still urinate through the urethra, you can still have bowel movements, but if you were to examine the vaginal area, you wouldn't be able to go very far. It would look normal on the outside, but wouldn't be adequate for penetrating vaginal intercourse. So lots of options there too.
You are just kind of amazing me. All the things I do not know or have not heard of. But I love that and I appreciate that so much and I appreciate you taking the time today for sure to talk to us because like I said, I want to normalize some things and I want people to feel I want them to feel good. I want them to understand that they're not alone and that they can thrive in all aspects of their lives. So I'm going to ask you one last thing.
Okay.
What is one thing you would tell any woman who comes comes into your office that they should be doing to thrive in their physical health? I mean, I know there's a lot, but if you could pick, like, I mean, if you could choose one thing that maybe either we haven't talked about or one thing that you found is most important in all of this.
So it's funny because I'm sort of a holistic kind of
Mhm.
person.
Mhm.
And so when I take a step back and I'm speaking with a patient about what would be prioritized in thriving, I would speak with her about quality of life, and what that means to her. And when they're in my office specifically, we're talking about quality of life and what's holding them back and doing what she needs to do in particular. So I don't think it's any one blanket answer for every woman. I think it needs to be sort of tailored to each individual woman because I think it's different for each woman.
Mhm.
But I think just recognizing that you have an issue that's affecting your quality of life and being brave enough to call somebody and make that appointment and make sure that you're safe and that you're healthy. I think that is
Yeah.
the best thing you can do to thrive.
Yeah. I had no idea what you were going to respond with that, but I think it's absolutely perfect because it is. I mean, you are absolutely 100% right that it's going to be different for everyone, but at least recognizing what that is for you, right? That's depleting you from quality.
Right.
Well, thank you. Thank you so much for spending time for me today, and thank you for coming on here and making the time. I know you're incredibly busy, and I just appreciate it, and I appreciate the conversation so much.
It is my pleasure. Thank you so much for having me.